Every major sports league and every team within has their own MVP. In the league that is medicine, in the sport that is cardiology, we are no different. We have an MVP also. On today's episode of Make It Make Sense Cardiology, I'm going to give you the highlight reel, and my God, I am excited already because I have so much to tell you. I am going to give you the highlight reel of our MVP, which is mitral valve prolapse. Let everyone who has an ear to hear and a heart to understand, please come on into the classroom, have a seat. Class is officially in session. Disclaimer, this is not going to be a quick 3 or 4 minute post. I will try to keep as brief as possible, but I need to be able to give you foundation, then clinical significance, and then treatment, and you just can't do that in 3 minutes when you are teaching for understanding and not just for pattern recognition. Ready? All right, y'all, let's do it. Now, the valves of the body, and valves are literally found all over the body. Valves have one job and one job only, and that is to keep blood flow moving in a forward direction, no differently than traffic on the interstate. Everybody needs to be moving in one direction. All it takes is for one less than smart driver to start backing up or moving in the opposite direction on an interstate, and you have chaos and mayhem and turbulent flow of traffic. And it even affects the traffic that's on the side streets coming into the interstate. It is just not a good look. Everybody needs to be moving in one direction. And again, that is the job of the valves. The valves regulate the direction of blood flow. Everybody move forward. You with me? All right. Now, in the heart, there are 4 valves that do this type of work. Today, we focus on mitral valve. The mitral valve is the valve that separates the left upper chamber of the heart from the left lower chamber of the heart. It sits between the left atrium and the left ventricle. Now, all of the valves of the heart have the capability to prolapse, but research and studies have shown us, and evidence-based practice has shown us, that of all of the valves in the heart that tend to gravitate towards prolapse, it's the mitral valve that does it more so than any of the other valves. Now, what does it mean to prolapse? Excellent question. Now, remember I said the purpose of the valves is to keep blood flow moving in one direction. So the valves accomplish that by being competent. That's the term that we use when valves are functioning like they are supposed to, like they were designed to do. So when the valve is open, blood flow goes through like it's supposed to. And then when the valve closes, the valve should close tip to tip. These are the valve leaflets. They should close tip to tip, so that when blood is moving forward, valve open, blood needs to just hold on for a minute, the valve will close from tip to tip. With prolapse, and again, any valve can do this, but mitral does it more so than its brethren. With prolapse, instead of those valves closing tip to tip, they will collapse backward on themselves. And when that happens, that sets up the very high likelihood that blood that was moving forward now has the ability to move backward through that collapsed valve. You see where that can be a problem? Now, mitral valve prolapse, how does this happen? How does it happen? The jury's still out to get a very definitive etiology of it, but from the research that has been done in the world of medicine so far, there seems to be 2 primary culprits. Primary culprit number 1, the umbrella term, let me give you this. The umbrella term for why that prolapse happens is called myxomatous degeneration. Big old fancy words. What does that mean? Myxomatous degeneration. That means myxomatous, well, you know what degeneration means, a wearing down over time, right? Myxomatous means that there is a waxy buildup, not necessarily a film, because it can, kind of blob up on there, but nonetheless, it's a waxy buildup that happens on the valve, an accumulation of this waxy product that happens on the valve. And when that happens, it compromises the integrity of the valve, makes the valve not very firm, not very taut, so it can open and close like it's supposed to, but makes that valve very floppy, so it ends up prolapsing on itself. Now, this myxomatous degeneration has been shown to come from two primary culprits. First culprit has nothing, and let me preface this by saying that either culprit has nothing to do with lifestyle habits. So it's not a matter of diet, it's not a matter of you didn't exercise, it's not a matter of you were smoking. None of that plays a role with mitral valve prolapse creation, if you will, where it comes from. Now, it can worsen mitral valve prolapse. It can, the lifestyle habits, but the cause, the culprit of mitral valve prolapse, number one, you've got genetic disorders, connective tissue genetic disorders. Think Marfan's syndrome. And it makes sense because connective tissue is what anchors the valve to the actual musculature of the wall. So if you have a connective tissue disorder, the valve's not going to anchor like it's supposed to. It's going to develop very oddly, and it sets up the propensity towards mitral valve prolapse. Culprit number two is an infectious culprit. More often than not, it's rheumatic fever. Rheumatic fever. Well, how do you get rheumatic fever? More likely than not, rheumatic fever develops as a result of untreated strep throat. Yeah. If this untreated strep throat just, is allowed to just, be run rampant in the body, that infection is going to set up shop on that mitral valve, and it's just going to wear away at it and eat at it and cause it to become incompetent, and there's your high risk for a prolapsed valve. How do you find out if you have mitral valve prolapse? Well, how do I know? You have an echocardiogram done. An echocardiogram is a basic ultrasound of the heart, tells us about general cardiac structure, general cardiac function. Well, how would I know to ask my primary care provider or my cardiologist that I think I might need an echocardiogram because I'm scared I might have mitral valve prolapse? Your provider, be it primary care, be it cardiology, your provider with every visit that you go to should be listening to your heart sounds. And if your provider hears a murmur in that mitral valve area, and it's a very specific sounding murmur for mitral valve prolapse, we'll get into that at another time, but if your provider hears a murmur around the auscultation site for the mitral valve, that's when an echocardiogram will be performed. Now, treatment of mitral valve prolapse is highly contingent on symptoms. Now, let's hypothetically speak, your provider hears a murmur, they get an echocardiogram. Echocardiogram says you have mild mitral valve prolapse. You didn't know because maybe you weren't experiencing any symptoms. You weren't having any shortness of breath. You weren't having any palpitations, skipping, racing heartbeats. You weren't getting any chest pain. You didn't know. This just happened to be an incidental finding. For that type and severity of mitral valve prolapse, no treatment is required. Remember, this is based off of symptom management. You don't just start medications for the sake of starting medications. Not at all. Now, if by way of mitral valve prolapse, even if you have a mild case of it as defined by your echocardiogram and you are having symptoms, that's when we need to start treatment. Treatment of choice from a medicine perspective, beta blockers. These are all of your initially designed to be high blood pressure medications, but for mitral valve prolapse, we're not using beta blockers to treat high blood pressure. We are using it to treat the symptoms that you are experiencing. Beta blockers literally tell that left lower chamber, that ventricle we talked about in the beginning, tells that left ventricle to slow down, fill accordingly before you attempt to squeeze and push blood out into circulation. Take some of that stress off of that mitral valve. That's what beta blockers do. Now let's hypothetically speak and say the echocardiogram shows that you have severe mitral regurgitation, severe mitral valve prolapse. The more severe the prolapse, the more high risk you are and the more likely you are to have that regurgitation, that backflow of blood that we talked about earlier. Severe mitral valve prolapse and subsequent severe mitral valve regurgitation, we are past the point of medications, and we now need to consider surgical intervention. Specific surgical intervention is going to be a conversation you have between yourself and the cardiothoracic surgeon. Could be replacement that's needed by way of either bioprosthetic or mechanical heart valve. Could be a clip that is put into place. Again, your specific surgical plan, if that's what you require, will be a discussion that you have between you and the surgeon. Just understand that mild cases of MVP, asymptomatic, no treatment. Moderate cases of MVP with symptoms, treatment. Moderate cases of MVP, no symptoms, no treatment. We just monitor with serial echocardiograms. And then severe cases of mitral valve prolapse with symptoms, you're headed for surgery. Mitral valve prolapse in a nutshell. Again, this is just a highlight reel. This is not, a discrete lesson. I just gave y'all like an hour, maybe an hour and a half worth of information in 11 minutes. If there's anything that I can expand on, I'm happy to do so. Just reach out to me. For those of you who found this information pretty interesting, share it with your colleagues. Feedback. Y'all talk back to me. Let me know if there's anything, again, that I left out, if there's something that you discovered about yourself with MVP, if there's a new finding that you discovered, new treatment options. Let's have a dialogue. Let's have a conversation. I don't want this ever to feel like it's a one-way thoroughfare. Not at all. This is a two-way street. I learn from you. You learn from me. Hit all your buttons. Repost, like, follow, share, all that jazz. Class is officially dismissed.